Hi, I'm Brad Power, and I'd like to introduce Michael Liebman, who's going to lead us discussion today on needing to have accurate diagnoses kind of at the front end if you want to have precision medicine. I'm probably going to misrepresent what he's saying, but something like that. And I'll just turn it over to Michael.
Okay. Thanks for the opportunity to meet with you all. So I assume you can see my screen?
Yep.
Okay. Let me put it in present mode. So what I'm going to talk about, just so everyone's clear, is I'm a modeler. I'm actually trained as a theoretical chemist, so I'm not a clinician. But I do have experience both in industry and pharma. I was global head of genomics and computational biology for Roche. I worked on the original HER2 testing with group thesis. And I ran a breast center for the Department of Defense, where we did everything from surgery back into molecular studies. And I have some academic appointments as well. I'm going to try to keep a short presentation, which for me is, it's a condensation of a 4-hour workshop I gave. So you'll hopefully bear with me. You're welcome to interrupt with questions, but I welcome all the questions you have at the end, and I have other slides that are backup that I may share as appropriate. And, you know, basically, we've heard of the central dogma for molecular biology, which is DNA goes to RNA, goes to protein. And basically, there's a central dogma for medicine, which is patient has signs and symptoms, they get a diagnosis, a treatment, and an outcome, as you're aware. But this process in here of interacting with a physician is actually fairly complex, because it depends on what the patient is bringing to the physician. And then it also depends on the environment that that physician is working in. And just as a point of reference, I'm co-leading an EU effort right now in cardiovascular disease, where we have 30 partners across 15 countries. And you can't imagine the complexity that this is across all of those different countries and research groups in a single disease. So what are the takeaways that I want to leave you with? Remembering that biology is about systems and it's about processes.
What?
And it's going always much more accurate to describe change than it ever is to describe something in an absolute sense. And that's just a general scientific observation. The other thing is, probably a lot of you are familiar with the term phenotype, and probably have encountered it in your personal healthcare journey. Phenotype really refers to an individual's observable traits, such as height, eye color, blood type. We're going to introduce the concept of next generation phenotype, and that's going to refer to how an individual progresses over time from a non-disease into a disease condition. And the reason for doing that is to enable a higher resolution of disease subtyping. An endotype is the subtype of a healthcare condition, which is specifically defined by basically a mechanism. And as has been written recently by Caliph and a number of people, really should be the target for drug development, understanding the mechanism. But one of the gaps and challenges we have is that we're frequently dealing with phenotypes and not something that really enhances the resolution of understanding individual paths through the disease. And so that's what I want to try to address and give you some perspectives on during this discussion today. And I term it a discussion, not a presentation. And I'll give you an example of what I mean by that. Here is a clinical trial. The outcome showed no effect over 6 years with a very large population. Statistical analysis, subgroup analysis, as you're probably familiar with, to try to recover subgroups did not enable them to determine any groups for which this drug was actually appropriate. The problem was the definition of the phenotype and the use of that phenotype to enroll patients into that trial. Because when we applied some novel methods, what we found is, as you can see here, I can explain it in more detail if there's questions later, there's actually 5 different progressions, meaning that there were 5 different populations and they would never should have been treated the same way. And not understanding that that complexity existed in the population meant that the drug may have worked for some of these subpopulations and not others. But it also indicates that, in this case, it was a heart failure drug, that these patients should never have been treated the same way because they don't fundamentally have the same disease. And that should back up not only into the clinical trials, but into drug development. Because if you want an endotype, you may need to understand that the mechanisms for these 5 diseases or 5 presentations or subtypes of diseases are actually very different. And so that's part of what we're talking about today. Now, when I should watch, oh, okay. The patient journey. We started out, as I said, I'm a modeler, with having a very coarse model of what a patient journey looks like. And I know you've all many of you have experienced a lot more detail than this. But essentially, you're going from a risk assessment to a diagnosis because of presentation of symptoms or clinical signs, what the physician's actually measuring, into that diagnosis, treatment, and then a variety of different outcome states. But in reality, you're just cycling back to become a patient again into possibly another disease or another state. The thing that you need to understand is that in all of this, you need to understand what is the question that needs to be addressed, because this actually is an observation of an economist. If you don't know how to ask the right question, you're not likely to discover anything that's going to be of significant value. And the question is going to actually be, in that patient journey, very different depending on who's looking at that patient journey. Because each of these groups is emphasizing a different part of this journey based on what they do, what their daily activities are, and what their priorities are. And none of them are necessarily looking at that entire patient journey. And so what we've focused on is really building a model of what this patient journey looks like, the complexity of that, and then allowing different groups to have their individual views, but also being able to expand upon their views to see how other factors may be actually interrelated to what they need to know. And the way we do that is, for those of, we use initially an ontology, which means we're basically looking at those concepts and figuring out all of the factors that are critical for those concepts. And then this actually goes many, many layers more deeply. But you can see what we built in general, because we use this across any disease, is something that's disease agnostic. And so there's no element in here that's specific to any given disease. And this becomes a model for how we actually integrate the data to actually represent and be able to analyze it. Now, it also gives you an idea of the kinds of resolution we're looking at. So we frequently talk about comorbidities, but comorbidities could be active comorbidities. In other words, another condition that you have as you're being treated for the one, in this case, prostate cancer. They could be inactive, meaning that they were previous comorbidities that may have been managed, and they may even be undiagnosed. And so the complexity of this patient journey is something we're trying to encapsulate in this form, and we actually convert to a knowledge graph. I won't go into that unless you have technical questions about what and why we do that. But what we're getting at is this. There's an ambiguity in diagnosis and staging. So if we take a clinical variable and we take 3 patients and we observe them when they come into the clinic, and this it scales up to many, many variables. So this is just for simplicity. What we see is 2 patients may present with the same biomarkers or clinical variables, but are progressing very differently over time. And 2 patients that are progressing exactly the same may not present with the same value because they came in to be observed in the doctor's office at different points in time. And this is a complexity that physicians are always dealing with. And Margaret Hamburg from the FDA used to say, clinicians have long observed the patients with similar symptoms may have very different illnesses. So it's something that's known, but it impacts a lot of what we need to do to understand the disease. So we need to understand that disease is a process that evolves over time, and it's not a state, although we tend to treat it as a state in terms of a diagnosis. And that disease process evolves in very, very high dimensional space, because essentially it could be any of your clinical variables or even your non-clinical variables like environment and lifestyle or social determinants that impact you as well. What the physician would really like to know is what's the direction of this high dimensional, I'll call it a vector for now, how far along that vector you actually are, and then how quickly you're progressing. And that's the ideal set of questions that a physician would like to ask, but they don't have a way to actually get those details. Now, mathematically, that means this isn't a vector at all, but it's a tensor, but we don't have the data to support that. And yet, what we know is if a patient comes in here, just as I showed you in that previous slide, they may get a different diagnosis than if they came in here or they came in here and be managed differently and have different outcomes. So one of the challenges that we have is we're always looking for biomarkers. We're always looking for clinical variables that we can use. Ideally, if we want to answer these 3 questions, we need to start off by knowing what this vector looks like. If we don't know what this vector looks like, then we don't know where a biomarker may be changing and what its value may be at different points in this vector. That also means that a lot of the biomarkers and diagnostics we have are available because of the technology we have that allows them to be measured. And as I noted before, we can see changes in them, but we don't necessarily know where they are appropriately aligned with this disease process. And that's a challenge that we tend to bury in the complexity of the problem because we don't have a good way to try to tackle it. And we don't have the data necessary to really do that on an active manner. So that's some of the things that we're focused on in trying to address. How do we optimize? And it's not what we would call a closed solution, but it's an iterative process to try to continually refine based on the gaps or the limited information we have, how to get a more accurate profile of the disease for the individual. Phenotypes, as I identified before, have the following limitation. If we have a set of observations and we have 2 patients for whom those observations are made, they could be symptoms, they could be clinical observations, laboratory studies. We know that they will exhibit somewhat different values. And over time, they'll end up in somewhat different places. What happens that we do right now is we'll take a specific diagnosis or a specific response to a treatment or a specific outcome and define that as a specific constraint, and then look to see where patients who have that characteristic may have common observations. So the idea would be, if we have patients, say, with prostate cancer of a certain type, what are the observations that different patients have who have that definition? And the issue is, they only occur at certain points in time in that progression, not throughout that progression. And so the overlap then is something that we're correlating with the outcome that we're superimposing on this population. So what we've done is we've said, the reality is this: those observations are correct, but they're not complete in describing how that patient progresses. Because while those patients in that phenotype all express that set of attributes, they have different attributes in the time period before and different attributes after. And these differences, these attributes and how they've changed, are different from these patients and different from these patients again. And what happens then is that if we all refer to these patients as having that same condition, we've obscured the fact that these patients are progressing differently than these and progressing differently from these. And this is what we use to generate what we call a next generation phenotype, or what I showed you in that earlier slide, which was heart failure, identify the fact that there were 5 different patient progressions that define the population that was being studied in that clinical trial. And we developed algorithms that do this, and some of them are now running on a quantum computer. And we use it to look at not only clinical trials, but diagnostic guidelines and eventually drug discovery as well. The other factor we need to consider is this: we are not making continuous observations yet. And the promise of some of the digital technology is we will start to have that potential, but that's a long way off. What we do look at is the fact that, almost like in a punctuated form, we make observations at some point in time and then talk about progression over that time course. But that progression is basically averaged. And what we're looking at in most cases, physician's perspective is, we're taking a normal distribution of that observation and we're saying, does that patient exhibit outliers from that distribution? And this is frequently the focus of what most physicians are looking for when they're running a Chem 20 or other kind of panel. Do you have outliers? But that normal range is going to be potentially biased by whatever population was used to generate those initial measurements. And the reality is this: what you see here are 2 patients schematically represented as never being abnormal, always within normal range, but you can see that they are moving in different directions. And we've shown in the past that using these kinds of tests and taking into consideration the discrete values rather than looking for the outliers allows us to discriminate as early as possible when these patients may have been on this path rather than on this path. And that's important to know for knowing how early could a diagnosis have been made and how early could a patient have been assigned to the right trajectory, a trajectory that might better align with the treatment than the average that they're getting right now. And so that's part of how we go about doing this kind of analysis. And the other thing that can take into consideration is, this is for the disease process we're talking about as the main problem. But every patient has on the order of up to 5 comorbid conditions, and frequently up to about 10 other drugs that they may take or supplements that are independent of what's being used to treat this patient or condition. And what that does is it actually alters that trajectory of the disease path. and the impact of all the diagnostics and the response to treatment as well. And to give you an example from a study we did in Italy, where we had population, we did an analysis of patients who have diabetes and hypertension. And for those of you who aren't aware, about 75% of the patients with diabetes have hypertension, and about 75% of the patients with hypertension have diabetes. And what we analyzed were the records for all of the drugs and all of the medications that these patients were taking. And what we found was that on average, approximately 67% of the patients who had either hypertension or diabetes were getting medications that were contraindicated for hypertension and diabetes because they were being given drugs for other specialties and other conditions. And that's part of the constraint of how medical practice takes place, but it's also a result of how clinical guidelines are being established and being implemented, especially by the specialty groups, because they're looking at focus on individual conditions, not in the patient in a more holistic manner. There are attempts to try to understand what progression may happen. This is from a study we're doing with multiple sclerosis. We're going back into a patient's record, their EHR. These are all the observations in the EHR for these multiple sclerosis patients. And what you can see is you can see the proportion of patients with different diagnoses who had some of these preconditions, observations in their record. But this is not adequate, because what you really want to know is, when did these occur? In what order did these occur? And which ones occurred together to really define the trajectory of that patient? And again, this is not how we're currently looking at a lot of these conditions. I can turn briefly now just to the prostate cancer examples. So here we talk about risk. And what you see is what we call an ambiguity, because you have effectively different stages associated with different risk levels. You can also see that risk assignment in different guidelines are not uniform. This requires a different kind of harmonization than is currently being performed, but is indicative of the fact that these are guidelines and not absolute definitions of conditions or risk factors. This is hard to see, but it gives you how these elements are defined. The important thing to take away from this is that there's a great deal of subjectivity in assigning these. But more importantly, there's this ambiguity that you have multiple stages that may have the same definition, but different parameters to make that up. There's two things that are involved here that you need to keep in mind. While the staging may be considered as a primary factor in administering treatment, the reality is that when we've analyzed this in breast cancer, because that's where we've done this in more detail, what we found is that, not surprisingly, patients are not exhibited to go through this in a linear manner. In other words, you don't progress from 2A to 2B to 2C and then to 3A. In fact, we have no idea right now how they progress, because a patient at the time of diagnosis would have to be treated. It would be unethical to try to follow the natural course of a patient who is not treated to actually be able to define the natural course of the disease. And the other thing is, the ambiguity in defining these may actually be obscuring the ability to understand what those discrete paths are. And so among the things that we've done is now try to reestablish with these discrete measurements how to redefine some of the stages. And we've applied Bayesian analysis to actually identify some critical paths of progression in breast cancer, but there's no reason to suspect that that's unique to breast cancer because it's a general set of characteristics. So let me stop, and I've got a lot of slides, but rather than just show you slides, let's open up discussion and questions. And then if something's relevant, I can show you that as well.
Thank you, Michael. I guess if people could raise their hands if they have questions, and I'll call on you. And while you're doing that, I will ask one question. Michael, why are there so many physicists doing this kind of work? We've had a number of people. Peter Kuhn is doing liquid biopsies and this work in modeling. I'm very intrigued by. We had one session on mechanistic versus empirical modeling from some gentlemen at Clemson. Could you just speak to a minute, just for a minute, on I'm very curious about that modeling aspect. What you laid out a process and measurement. What's been your experience or lessons from modeling in general?
Well, as I said, I'm actually trained as a theoretical chemist, but I've never been in a chemistry department.
Okay.
I don't think they would let me in a chemistry department, to be honest with you. My interest is in solving problems, and the 4-hour workshop that I mentioned was for the Society for Decision Professionals. And so I'm interested in how decisions are being made, the adequacy of the data and knowledge used to make a decision, and the decision process. And a lot of those things are very fundamental. So when I look at problems, the purpose of going to the ontology, which I told you was disease agnostic, is because I'm interested in looking at root cause problems and seeing that a problem that someone may think is very, very specific actually represents a class of problem that maybe someone else in another discipline has solved and doesn't have to be resolved again. And can we borrow that technology, adapt that technology, and learn from the experiences in those other domains? So a short example is we model and simulate biological pathways, but usually when, as a chemist, we would model a pathway using kinetics and set up what we call differential equations and rate constants to simulate the behavior. But we don't know any of those. We don't know most of those, or they're not measured under the same condition. So what we did is I said, a pathway like you have here, a biological pathway, is very much like a communication network, a series of towers that you have moving signals around. And biology is just moving a signal around to accommodate blockages, inhibition, mutations, and so on. And so what we did is we went to the engineers and borrowed their communication engineer tools to actually allow us to simulate that behavior, because it's exactly the same problem, just implemented in a different way. And we could ask questions in a qualitative way that we really needed to answer, while everyone else is waiting for quantitative data that we may never get. And so in modeling, that's part of the approach that we take.
It sounds very familiar to the description we got on proteomics from Karen Rodland, looking at pathways between the cell and the nucleus, and MEC pathways and other pathways, and looking for biomarkers. It also sounds similar to the mechanistic approach that the folks from Clemson were doing. Maybe I'll put you in connection with them. You might be interested in making that connection.
Yeah.
Jeff Waldron, you had your hand up first. You're on mute, Jeff.
There's a lot of people that wish they could mute me. This was great, Michael. Thank you very much. I enjoyed it a lot. It's obviously very thought-provoking, and we're all working this area, so we are familiar, but we're at different aspects. So two things that are probably too high of a level of a question, but one comes to mind is, diagnostics has really been what's been one of the things that's been transforming healthcare a lot, but it's getting very hard now because there's so many diagnostic options, you know, from next gen sequencing and proteomics and multiomics, like he just said. But also you have all these companion and complementary diagnostics that are tied to a particular therapy. So it's not like a patient presents with a condition or series of
Right.
conditions and you say, oh, that means I need to do this test. It's the picking of the diagnostics, including potentially soon liquid biopsy diagnostic tools, is really difficult now for physicians, it seems like. And that's why what I see us doing is what you're talking about, is we're moving to algorithm-based medicine. Because then the other big trend I'm seeing in the groups I work with is this whole combination therapy versus monotherapy. So you're now picking combination of therapies, not a linear progression of first, second line of treatment. It might be, you know, 2 or 3 different drugs at different doses as the first line, or
Right.
neoadjuvant therapy. So it's, the algorithms are just getting insanely complicated, it seems like. And I know I'm talking up Allie's alley here also.
Yeah. In fact, I can show you. So let me just show you, this might be of interest. We were interested in a pathway, and I think I have it here. No, I have it in another one. We were interested in understanding a given drug. Now, this is breast cancer, so it was a aromatase inhibitor. And in breast cancer, there's the use of HER2/neu, which you may be familiar with as a biomarker, that about 20% of the patients overexpress HER2/neu. And part of the problem that we identified was that, I thought I had it in this, is that, well, part of the problem is that there's 2 different ways to measure it. And the reality is, in practice, HER2/neu is supposed to be a diagnostic, companion diagnostic for a certain treatment. But 66% of the women who are eligible for testing are never tested. So the practice isn't compliant at all. And that's because what I showed in that earlier slide is partially the effect of patient pressure. They've
Yep.
heard that the drug is available, it's less toxic than other drugs.
Yep.
And so they ask for it. The problem you have is, in this case, if you use it and only for 40% of the women respond to the drug.
Mm-hmm.
So you have the cost of the drug, you do have side effects, but the drug is a biologic, and effectively what it does is it alters the course of the disease.
Right.
So by the time you find out it didn't work, you're not quite sure what the next drug is that you need to use.
Yep. Yep.
And this is a general problem. The other problem the FDA caused is they've approved 2 different tests, an immunohistochemistry test and a genome test, that's a FISH test to look at the number of gene copies. Well, if you go back to this slide, one is being measured here and one is being measured here. And the one thing we've learned is there's a lot of steps in between.
Mm-hmm.
And it's not a one-to-one transition. And the problem you run into in reality is this: we measured in our patients both tests, and the concordance that they say is about 20%. Well, it's really good if you have a very benign disease, and it's really good if you have a very aggressive disease. But the majority of patients are here, and it's really bad.
Mm-hmm.
And the reason it's bad is you're measuring 2 different processes.
Mm-hmm.
And what you may be obscuring is the fact that neither of those is the correct process for the biomarker. But
Right.
those are the ones that are measurable.
Yeah. No, that really gets that. I'm assuming maybe you work with my friend Sridhar Ganesan at Rutgers. He's been involved a lot in this area in breast cancer. He's at the
No.
Rutgers Cancer Institute.
Yeah. Yeah.
Thank-
No, no, I haven't actually.
Thank you.
Okay, next up, Brian.
Hi, Michael. This was a fascinating presentation. I think you captured so many of the challenges that patients have, and the complexity of what we're dealing with. You know, I think there was one slide that kind of showed what the patient experience is. We refer to that as the conveyor belt of death. Right? We're trying to get off of that. I think also your discussion today is very, very complimentary of like Bob Gattenby and adaptive therapy. This whole notion of having like a single extinction event, for complex disease is crazy.
Mhm.
And so you really have to think about strategically, what will your treatment, what's your next treatment, and what are, subsequent treatments going to look like, and how's that going to actually, each pressure going to change the direction of the disease. So I've got a few questions, but the first one that came to mind is, how are you working with clinicians to actually integrate this approach to problem solving in the clinic for patients? Because
lot of it's-
again,
yeah.
if you kind of like look at the dogma from DNA, RNA, and proteins, what's driving those changes in proteins, right? They're just not magically just happening. There's something biologically that's happening. And so you have to look beyond just those three
Well,
elements. So anyway,
Yeah, it's not only that, but you have to look from a modeling perspective. It could be a change in the protein itself. It could be a change in the level of the protein. It could be a change of when the protein and where the protein is produced. There's all different factors that go into the function of the protein, not just the fact that it's a protein coming out of that. And so, like in asthma, where we have alpha-1 antitrypsin, is the lung being attacked because the inhibitor of the elastase doesn't show up at the right time, but it's there. And that may be a different condition from when it doesn't show up at all and needs to be managed differently. But we have to ask those questions, start to ask those questions. Now, I work primarily with clinicians, which is why I said the first thing that when I was running the breast center, I worked with the chief of surgery at Walter Reed, and this is during the Gulf War. So you can imagine he was busy, and getting his attention to do research was not necessarily obvious. But what was clear was helping them do their job better and helping them identify the questions they don't ask is what's critical. Because physicians have to be very operational, especially based on economics, time, and everything else. And they're not normally trained in research. I mean, obviously some are, but the majority of them are not. And the patients would like an answer when they leave the office. They don't want someone to go off and do research on it per se. And so they have to be very operational and not strategic. And what we're trying to do, what we typically do in most of the diseases, is we try to figure out strategically what are the questions that they would like to have answered, and how do we try to address those. So an example is I'm co-leading a big EU program. It's 30 centers in 15 countries in cardiovascular disease. And it's all with cardiologists. And they basically start with when the patient shows up. And the issue is, how early could you have determined before that patient showed up that they were actually having cardiovascular problems? Is the measurement of risk, the way we're doing it now, they know it's inadequate. And are they really detecting early disease, or are they detecting risk for disease? And how early could you have determined which path they're on so that you might have been able to intercede, some of which could be patient empowerment, and others might be actually intervention. And those are the questions physicians want to know in general, but they don't have the tools to ask or try to address. So when we look at MS as an example, the clinicians we're working with, they're almost solely focused on the issue of what is the right drug for the patient with this diagnosis. And they will admit they don't trust the diagnoses, but they don't have the option of knowing what they can try to do to change that. And that's where the opportunity is for research, and also empowering the patient to understand some of that, and just realize that that's the reality, because it is the reality. You know, we right now in MS, it's easy to do a survey of patients to ask questions about what did they experience before they came into the physician's office. We're actually collecting unscripted patient histories. What was everything that you ever experienced that you may never have gone to a doctor for? Because we want to understand what of those may actually have been early signs. And so it's changing the paradigm, but changing the paradigm is very hard, as you can imagine.
You may have alluded to this, but this was a question that, I mean, your presentation sparked some questions that I had very early on in the disease, which is absent of concrete observations, you know, can you go back and model the drivers of the disease manifestation?
Well, you're trying to do that. And when you say absence of early observations, you're taking into consideration things that you may report to a physician or a
Correct.
test that they may run.
Yeah,
And the reality is they may not be the right tests.
right.
And so part of what we try to do is we're actually weaving together. So if we take a look at this cardiovascular project, we're taking all of the existing databases that are out there, but they all start with the patient coming in to be diagnosed and treated. We're putting at the front end all of the databases that come from the Netherlands, they come from Norway, they come from Sweden, they're coming from Finland, where the Scandinavian countries in particular have been following patients without a diagnosis for 30 or 40 years to see how they progress over time without knowing what to expect. And we're putting that at the front end to say, these patients are progressing similarly. And we don't know, maybe they won't get heart failure, but they're likely to present with the same condition at some point. And some of them will be heart failure that will be able to keep going back earlier and earlier. And what are the markers that we might want to now include in a conventional study that we're not including? And so that's how we're setting this up, to be able to drive new studies by identifying some of these earlier markers that aren't being used, because it's easy to look at the markers we have and know they're not adequate.
So sorry, man, I'll yield to the floor here in just a second, but each one of those databases have certain biases.
Right.
So how do you account for that?
We incorporate that. And in fact, that's one of the things we're focused on. We're using a unique federated model. And in that federated model, we're actually looking at how each data field has been defined. And so an example would be in one of the measurements is glomerular filtration rate. So it's looking at kidney processing. Well, all the databases have GFR reported, but there's 5 different algorithms to compute GFR, and they're not equivalent. And some include race and some don't include race. And so you need to know what is the algorithm that was used to develop that value to be able to do a meta-analysis and incorporate that data, understanding what biases may be in it. Because if you don't, you're mixing oranges and apples.
Yeah. Yeah, yeah, there's that element of bias, but then there's also, there could be a bias just in terms of the actual source. You mentioned you're getting a database from Holland. Well, how would the lifestyle of, a Dutch person compare to, somebody in Philadelphia?
Yeah, well, there in the modeling, what we do is we usually model things within the database, and then we evaluate the models across the databases. And that gives us an idea of what kind of, in the US, and you mentioned Philadelphia, we have a study going on where we're comparing 12 different immigrant populations in Philadelphia. And we have exactly that. What are generalizable and what are unique to those cultural groups?
Okay. This is fascinating, but I will let others jump in here.
No one else has raised their hand, Brian. You can keep going if you want.
Oh no, I don't want to subject everyone to this. You mentioned NCCN guidelines, and before you mentioned that was one of the questions I had is, are you working with people at the NCCN guidelines to elevate what they provide to clinicians and to patients? Because it is very operationally oriented. It's, if then, right? So yeah, I'm just curious if you are connected into those groups.
Well, we look at guidelines more than just NCCN because we're working internationally. One of the things we're actually comparing is claims data to guidelines. And the reasons we're doing that is claims data is what's being done for reimbursement purposes. And guidelines are what are being recommended for practice. And there's a very common difference between them because physicians are obviously responding to what needs to be done for reimbursement. And based on their experience, may or may not follow guidelines. And the guidelines, the highest form of having come out of pharma, the highest form of evidence for an evidence-based guideline is a randomized clinical trial. But just as I showed you in that very early slide about heart failure, that was biased because they used a inclusion-exclusion criteria that didn't actually approximate the real-world population. And so we're looking at these from that perspective. We're not working directly with the groups that actually administer it, other than to show where there may be weaknesses. We're trying to enhance transparency. So we don't make judgment, but we're working to enhance the transparency of where certain data may be less reliable than other data that's being included.
Jeff, you have a question.
Yeah, I was just going to add on to that a little bit. One of the areas I've been working in, Michael, is pharma expanded access programs, which you're probably quite familiar with. And, my problem with clinical trials is they pretty much cherry pick, patients with early stage disease and few comorbidities because they want to get the drug approved.
Right.
And you may be on the placebo arm of the trial also, whereas patients on a third or fourth line of treatment, if they can gain access through an EAP program to an investigational drug, maybe they've exhausted all the standard of care options, can be transformative. But it just seems to be, I'm trying to work with several companies now to sort of facilitate this process because it's a amazingly sort of basic but immature process where you basically apply to the FDA and the pharma company, and you have to show that you have no other options and that your physician believes you'll respond to this particular therapy.
So our approach is a little different. What we're saying, again, because of, as you pointed out, and I tried to point out, the RCTs are all biased for success, as
Right.
you would expect.
Yep.
We actually, when we do our stratification, don't include the RCT data.
Hmm.
We look at real world patient data,
Yep.
and that gives us a profile of what the real world looks like. Then we would go back into a failed trial and re-diagnose the patients
Yep.
to see where the drug would have worked.
But what I'm trying to convince pharma, not only the EAP program is good for patients, I think they should be gathering the data on those patients, because that's what you just said. Those EAP patients are probably more representative of post-commercial pool of TPP, whatever the target patient population.
Right. Well, the one difference is, or the one aspect is, because they're small populations,
Right.
it's hard to show statistical significance.
It's narrow. That's true.
Yeah. So we
But if
use
we
it,
expanded, it could become less narrow if people and
right.
providers, usually it's from academic medical centers where they're already doing the trial with trial patients, and they're then, for patients they have no other options, they're offering it or
Sure.
soliciting the EAP access.
Yeah. Yeah. No, that makes perfect sense. But we're trying to see how you can expand upon that by understanding that complexity.
Yes.
And actually, one of the things we're doing, because I think as you would agree, pharma has sort of targeted in that entire process what the population will be.
Yes.
Commercialization already knows where it's going to go. They've started to prepare the marketing materials and everything else in
Yep.
anticipation of approval. What we're doing is by redefining those diagnoses and identifying where the drug, maybe a failed drug, worked or didn't work. We can show for a small biotech how they can go around pharma,
Yes.
because they can identify a niche group for whom the drug would work, and it's too small and too hard for pharma to re-engineer the whole process, and
Yep.
so they won't deal with it.
Yep. Yep. We'll
That's-
catch up. I will send you a note. We'll catch up
Okay.
later on, I hope too.
Okay.
Thank
Yeah.
you.
Yeah.
So we're running out of time. I don't know if anyone has any last questions, but Michael, thank you very much. I was just sort of curious if you had any parting words of wisdom or any kind of summary messages. I've been very impressed by your ability to go to first principles and not just sort of take the process or the conventional, accepting things that are very fundamental in definition. And I love the word ontology. You know, so you know you're very grounded and very solid on definitions and what's going on, and it seems like with that you come up with very unique insights. So I just think that this is very refreshing to show that there's we have to kind of reflect on every step in the process and not just take for granted some of the things like the process in RCT, which is kind of wholly and irrefutable, a sacred cow, if you will. So anyway, just kind of parting thoughts on that general, just kind of your approach and your lessons from that perspective on these processes.
The biggest takeaway we always have is it's the hardest thing to change is culture. And we can have all the evidence we want, but when someone believes that this is the way you do it, it's very, very hard to get those changes in place. And pharma, for instance, is organized to support a specific mechanism of development, discovery and development, and very, very hard to make change, which is why I left pharma, basically, because we couldn't make those changes internally. So I think the patient has to be a spokesperson for their condition and has to be open to understanding that physicians are 99% doing the best they can, but they have limited information. And I'll leave you with one anecdote from when I was at Mount Sinai. And I used to have constant battles with the dean of medicine because I was in the basic science side. And so the cultures don't always mix for a variety of reasons. But I went to the first day of class for the new med students one year. And he got up there and he was a real large individual. And he said, you know, we're going to spend the next few years cramming your heads with so many facts that you won't really be able to learn them all. And he said, but you need to understand, half of the things we're going to teach you are wrong. And then he said, and the real problem is we don't know which half. Okay. And that was probably the most honest thing I've ever heard.
Let me just close with your answer to a challenge, and I'm thinking of Brian. Brian has a very, I don't know, let's say, he leans into two things. He leans into more testing is better, and he leads into wanting to have a treatment strategy, not just be on this hamster wheel of try one thing and it works for 12 months and try another thing and it works for 12 months and try it. He wants to have more of a strategy. And he is frustrated that he can't find that sort of alignment with his treating oncologist. And so the question then is, should he just do what he thinks is right? Or should he find another clinician, or it's kind of you've been focusing on some of the culture of pharma. He's been focusing on the culture of providers.
Yeah.
What would be your advice in that environment?
I'm dealing in Europe with groups that are called integrated health providers or integrated health. And they work internationally, but they have a much broader or more holistic approach to treating the patient. An issue we're always going to be faced with, right, especially now, is the issue of specialization. And the issue of specialization means that there's very, very deep understanding or knowledge about an area, but it doesn't have enough breadth sometimes to look at what those boundaries really need to also take into consideration. So I think I can point you to the integrated health group that I am working with. I don't know what their connections are in the US. I can ask them. I'm sure even if they're not formally linked, they probably are aware of groups that would have that same kind of philosophy. And that's probably closer to what you're looking for, I think, than the oncologist who goes to ASCO and then wants to use the drug that they were talking about in the last lecture, kind of thing.
Yeah. I mean, I'll give you a good example.